try to discuss as a group here. Okay. So with this presentation, I will try to cover a little bit introduction about the in vivo dosimetry, some background and principle of in vivo dosimetry, techniques and tools, application of in vivo dosimetry, challenges and limitations of this, and some future perspectives, and we'll conclude after that. So, in Latin, in vivo means within the living. So, in vivo dosimetry, this IVD in radiotherapy is the direct measurement of radiation dose on or inside a patient to verify treatment accuracy and ensure dose delivery within the prescribed tolerances. It serves as a quality management tool to detect errors early. This often utilizes diodes, TLDs, OSLDs, or EPIDs. So, by definition, we can say that in vivo dosimetry is a vital component of modern radiotherapy, ensuring accurate and safe delivery of radiation doses to patients by measuring dose parameter during the treatment. So, we can say that in vivo dosimetry in radiation therapy means the measurement of radiation doses received by patient during treatment as compared to ex vivo, which means dose measurement in a phantom. So, this IVD refers to the measurement of radiation doses delivered directly to the patient during radiotherapy treatments. Unlike pre-treatment dose calculations or phantom-based measurements, IVD provides real-time or near real-time data on the actual dose received by the patient. This plays a significant role in maintaining the accuracy and reliability of radiotherapy treatment. So now, what is the purpose of this in vivo dosimetry? There are three purposes. First is to ensure precise dose delivery to the target area. Second is to ensure patient safety by identifying and mitigating potential deviations from the treatment plan. And third is to validate treatment plans by providing feedback for QA protocol, quality assurance protocols. So, through these functions, in vivo dosimetry acts as a safeguard against the errors arising from equipment malfunction, patient positioning inaccuracies, or anatomical changes during the treatment. So let's discuss something about the background of this in vivo dosimetry in a few slides. So the practice of dosimetry in radiotherapy has evolved significantly over the years. Early approaches relied on simple ionization chamber and film dosimetry, but they lacked the accuracy and adaptability for increasing complex techniques. So, major milestone was the adoption of thermoluminescent dosimeters (TLDs) in the mid 20th century, and subsequent innovations introduced electronic dosimeter such as diodes and metal oxide semiconductor field effect transistor, there's MOSFETs, which enabled real-time or near real-time dose monitoring. The development of electronic portal imaging device, that EPIDs, further enhanced dosimetric capabilities, integrating imaging and dose measurements. Now, what are the principles of in vivo dosimetry? So, IVD is based on fundamental dosimetric principles, including dose, energy, and spatial distribution. So, dose is defined as the amount of energy deposited per unit mass of the tissue. Energy is defined as the penetration depth of the radiation beam and its interaction with the tissues. And spatial distribution ensures that the prescribed dose is accurately delivered to the target area with minimal exposure to surrounding tissues. So these three principles provide the foundation for the precise measurement and validation of radiation treatment. So how to perform the in vivo dosimetry? So this IVD utilizes both passive and active dosimeters. So passive dosimeters like TLDs and film dosimeters are widely used for point dose measurement and spatial dose distribution measurements. And active dosimeters, including diodes, MOSFETs, and OSLDs, provide real-time or near real-time dose measurements. So, what are passive and active dosimeters? Passive dosimeters are TLDs, thermoluminescent dosimeters, and film dosimeters. So TLDs, we know that they store energy in their crystal lattices, and this energy is released as light upon heating, and this provides cumulative dose reading with high accuracy and reusability. Whereas film dosimeters offer a high resolution visual representation of dose distribution, uh, and they are single use and they require labor intensive processing, so they are having this kind of challenges in using these film dosimeters. Now, active dosimeters. So active dosimeters are diodes, MOSFETs, and OSLDs. So these diodes are highly sensitive and they are commonly used for point dose verification. MOSFETs, they are particularly advantageous for small treatment fields due to their compact size and precision. And OSLDs use light to stimulate the dosimetric material for dose readouts, and they are favored for their sensitivity, stability, and reusability. Now, what are the factors affecting the in vivo dosimetry accuracy? So, the accuracy of IVD is influenced by beam characteristic and patient specific factors. Beam energy and beam quality play a significant role in determining the depth and uniformity of dose distribution. Advanced techniques like IMRT and VMAT introduce dose and intensity variation, so they add more complexity to the measurement. Anatomical factors such as tissue heterogeneity and patient movement, they also impact the measurement accuracy. So, what are the techniques and tools to perform this in vivo dosimetry? So, first is TLD, the thermoluminescent dosimeters. TLDs are widely used passive devices that measure cumulative radiation doses. Clinically, TLDs are employed in applications such as point dose verification and total skin electron therapy and TBI, the total body irradiation. Their benefits include their compact size, reusability, and relatively high accuracy. But the limitation include the need for specialized equipment for their readout and lack of real-time feedback. So, although it has some benefit, it has some challenges also to perform this IVD. Now, the second is semiconductor diodes. Below, you are seeing these semiconductor diodes, and the same we can use for the patient measuring for measurement of the skin doses. So these diodes are active dosimeters that provide real-time data during the radiotherapy treatment. These semiconductor devices are highly sensitive and capable of measuring radiation doses instantly, instantaneously. And this makes them ideal for monitoring treatment sessions. It's commonly used for point dose measure verification in external beam radiotherapy techniques requiring high precision. But the drawback is they are sensitive for temperature and angular dependence. So this is the drawback of using diodes. Next is MOSFET, the metal oxide semiconductor field effect transistors, MOSFETs, and they are another category of active dosimeters and valued for their miniaturization and ease of use. So in picture you can see some tiny MOSFETs, and they are placed on the skin of any patient or human, and we can check the dose received by that particular area. And so their small size allows them to be placed in hard to reach areas, particularly useful for pediatric treatment and small field dosimetry. They provide real-time dose measurement and are relatively easy to calibrate, but they are more sensitive to cumulative radiation damage compared to other devices. Means if their life is up to a certain dose received by them, and if the dose is level is reached, defined by the specification. So after that, it will be damaged and will not be useful for any measurement. Next is electronic portal imaging device, the EPI. So we are seeing this almost everywhere in the Linux setup, and they represent a significant advancement in real-time dosimetry during the treatment. They were originally designed for the imaging, but adapted for dosimetry purpose by analyzing the radiation beam intensity profile as it exists the patient. So in the picture, you can see that the radiation beam, photon beam, exiting from the patient body is received by a amorphous silicon detector, and after that it is recorded by the device. So with this camera based IPRDs are some old one, But now this amorphous silicon-based APRDs are coming with very high resolution. So they are the modern APRDs. They are particularly effective for verifying dose distribution in complex treatment plans such as volumetric modulated arc therapy VMAT. Next is optically stimulated luminescence dosimeter, that is called OSLDs. OSLDs are newer addition to in vivo dosimetry, and this offers several advantages over traditional tools. OSLDs measure doses by stimulating a radiation sensitive material with light, which releases stored energy in the form of luminescence. They provide highly accurate cumulative dose measurements. They are reusable and exhibit excellent stability over the time. They are particularly useful for monitoring dose distribution in treatment like TBI, and they are also commonly used in intraoperative radiation therapy, providing the skin doses in breast cases. The picture is showing some nanochips. They are the OSLDs, and these chips or OSLDs we are placing on the patient body or wherever the location we define, and simply we place the OSLDs and expose, or the whatever treatment is received by the patient, it will be recorded, and later on we can analyze and we can document the that dose received by the patient. Next is a radiochromic film. We are aware of this type of films being used in the clinic, and radiochromic films, for instance, provide high spatial resolution and are ideal for complex dose distribution measurements. These film change color in response to radiation. So their dose response characteristics can be analyzed with optical scanner. Just expose, and in any optical scanner you can scan them and you can find out the result with better accuracy. When we have all seen in the case of this type of film in brachytherapy for source position accuracy, also for star pattern and picket fence tests in Linux, and optical field congruence in Linux, and few times when it permits, we can take the radiochromic film for the measurement for the dosimetry of treatment plans also. This will give you the intensity profile after the processing. Next is fiber optic dosimeters. So I've shown this this fiber optic dosimeter here. So these represent another cutting edge innovation. They offer real-time dose measurements with minimal perturbation of the radiation field. And these dosimeters are highly flexible, suitable for placement in challenging anatomical locations. They are resistant to electromagnetic interference, making them a promising tool for use in advanced radiotherapy technique. So this table has overview of whatever we have discussed till now in this class for in vivo dosimetry. starting from the TLD, diode, MOSFETs, BID, OSLD, radiochromic films, and fiber optic dosimeters. The table is showing you the characteristics, their applications, their advantage, and of course, the limitations also. Now, application of in vivo dosimetry. In vivo dosimetry plays a key role in ensuring the accuracy, safety, and effectiveness of radiotherapy. Its application extends from external beam radiotherapy to brachytherapy and specialized cases addressing unique clinical challenges and enhancing patient-specific quality assurance products. So, in case of external beam radiotherapy, the application of IBD is there. In vivo dosimetry is important for complex treatment plan verification. These highly conformal plans demand precise dose delivery to irregularly shaped targets while sparing the surrounding healthy tissues. So, in vivo dosimetry is also employed to monitor and minimize exposure for radiation sensitive device and structures during the treatment. Like if a patient is having pacemaker, or we have to restrict the gonadal doses for any patients. So IVD is also useful in those cases. Additionally, in vivo dosimetry facilitates the measurement of peripheral doses using OSLDs or TLDs. Their application in heavy particulate therapy, including proton and carbon ion therapy, is also very crucial. So, IBD is having the effectiveness, usefulness in EBRT. Second is application of IBD in total body irradiation, TBIs. So, the picture is showing two different type of setups. Uh, the conventional setup where we were doing it, we were exposing the patient with lateral setup where the gantry was either 90 or 270 with a certain distance. Patient was positioning on a wall like that. We have treated so many patients. So there also the SLDs we can place, and we can check the reading, we can check the doses, and in newer techniques where like in our institute we are delivering TBIs in tomotherapy. So this first picture is now we are utilizing this position for TBI QA, and we are placing the OSLDs on different part of the human body, and we are exposing and receiving the doses. So in TBI, this in vivo dosimetry is very useful. The accurate dose delivery throughout the entire body, essential to achieve uniform therapeutic effects while avoiding excessive toxicity to critical organs. TLDs and OSLDs are widely used for patient-specific QA and TBI. They provide reliable dose measurement at key anatomical location. So I can say that using OSLD is very useful in the treatment of TBI for better understanding of what we are delivering, what we have planned. Third is in brachytherapy. So it has application in brachytherapy also. This in vivo dosimetry is vital for ensuring accurate dose delivery, where dose gradient can be steep and any minor deviation can significantly impact therapeutic outcomes. In high dose rate brachytherapy, in vivo dosimetry serves as a critical safety measure, providing real time dose verification to prevent over or under dosing of the target tissues or adjacent organs at risk. So, this picture is there are two pictures actually. First picture is showing uh, patient having a in this brachytherapy procedure, and the source the signal from the source is received by flat panel detector, and this is received and analyzed by the planner. The second is a prostate case where we have used a MOSFET to analyze the doses received by the nearby structures and of course by the target. This IVD is having a role in pediatric radiotherapy also because a small child and they are very sensitive to the radiation. So this in vivo dosimetry is of course having the role for pediatric radiotherapy cases. This represents unique challenges due to developing tissues, heightened sensitivity to the radiation. In vivo dosimetry is especially important in this context. Techniques such as TLD, OSLD, and MOSFETs are frequently used to measure the doses in pediatric cases, accounting for factors like patient movement and tissue heterogeneity. Use of in vivo dosimetry enhances the treatment safety and achieving optimal treatment outcomes. So we can say that in vivo dosimetry is very useful in pediatric radiotherapy cases. Now, what are the challenges and limitations? So, first we can say, starting from the measurement uncertainty, accurate dose measurement in vivo dosimetry can be affected by few following factors. First is calibration error arising from improper or inconsistent device calibration. Second is positional deviation, such as incorrect placement of dosimeter on the patient, especially in treatment with the steep dose gradient and small fields. Third is patient anatomy variability, including changes in tissue composition, density, or positioning during the treatment, can alter dose distribution and accuracy of in vivo measurements. And fourth is perturbation caused by the dosimeter themselves, particularly in the small fields. So these are the measurement uncertainties. They are affecting the outcome of in vivo dosimetry. Second is a technical limitation. Technical limitations of in vivo dosimetry system can impact their performance and applicability. Like TLDs are sensitive to environmental conditions such as temperature and humidity. OSLDs and diodes offer limited spatial resolution, making it difficult to capture detailed dose distribution with a steep dose gradient or complex anatomy. Various factors such as direction, energy, dose rate, and temperature can influence in vivo dosimetry readings. Angular dependence, energy dependence, and dose rate dependence is a very critical factor. Temperature fluctuation can also impact the dosimeter reading. So these are the technical challenges, technical limitations. Now, third is the clinical integration. The integration of in vivo dosimetry into routine clinical workflows can present practical challenges also. Additional steps required for dosimeter preparation and data analysis may interrupt the standard workflows and increase treatment time. The cost, of course, of acquiring, maintaining, and calibrating in vivo dosimetry equipments can pose financial barriers. Passive dosimeter like TLDs and OSLDs, while cost effective per use, but they require specialized equipment for readout, adding to the overall expenses. And active dosimeters such as MOSFETs and diodes often come with a very high initial investment and maintenance costs. So there are challenges also to incorporate IVDs in the clinical setups. Now, what are the future perspectives? With the help of emerging technologies, uh, artificial intelligence is very modern subject to be available in the market, and machine learning are poised to revolutionize in vivo dosimetry by enabling predictive dose analysis and real-time adaptive feedback. Integration of 3D dosimetry systems into clinical workflow provide the ability to visualize radiation dose distribution in greater details, enhancing the accuracy of dose delivery and ensuring treatment precision. Monte Carlo simulations models, they are increasingly being integrated into the clinical workflows. So their incorporation of Monte Carlo simulation into the in vivo dosimetry allows clinicians to verify dose delivery with greater confidence. So, with the help of these emerging technologies, in vivo dosimetry can be more important and helpful for the clinical practices. Now, advancement in detector materials and nanotechnology. The development of advanced detector material and the application of nanotechnology are unlocking new possibilities of in vivo dosimetry. So, nanowire based dosimeters. Now, these are the new things. Nanowire based dosimeters offer superior sensitivity and precision compared to the traditional dosimeters. So, with the help of advancement in detector material, this IVD can be uh, more newer and helpful for the clinic. Third is the integration with the adaptive radiotherapy. So, adaptive radiotherapy, this involves modifying treatment plan in response to changes in patient anatomy or tumor characteristic. So, we can say that IVD is expected to play an important role in this modality by providing a real-time dose feedback and their seamless integration of IVD with this adaptive radiotherapy could significantly enhance the precision and effectiveness of the treatment, ensuring that the dose delivery remains optimal despite any anatomical variation. Fourth is integration with the flash radiotherapy. Flash means definitely we can say that very high dose can be delivered in a very lesser time. So there also this in vivo dosimetry has a role, and this is a most exciting advancement in radiotherapy. And this flash radiotherapy, we all know that this involves delivering ultra high dose rate in a fraction of the time compared to the other conventional therapies. With the help of a nanowire based this OSLDs as emerging promising tool for measurement of radiation dose, uh, it will be helpful in flash radiotherapy also. Fifth is individualize patient dosimetry and real-time feedback. Uh, the move towards personalized medicine is also influencing the future direction of in vivo dosimetry. Advances in dosimetry technology paving the way for individualized patient dosimetry, where measurements are tailored to the unique characteristic of each patient anatomy and treatment plan. So this capability not only enhance the treatment accuracy, but also improve the patient safety by identifying and addressing the potential error before they affect the clinical outcomes. So we can individualize the patient dosimetry for every patient depending on the anatomy and their treatment plans. The in vivo dosimetry will give the real-time feedback, and we can assess our plan. We can analyze our plan, and we can recheck depending on the results what we have received from the IVD. So we can conclude that this in vivo dosimetry plays a crucial role in ensuring the accuracy, safety, and quality of the radiotherapy. This provides essential real-time verification of dose delivery during the treatment. In vivo dosimetry is particularly important for advanced treatment modalities such as IMRT, VMAT, and emerging techniques like flash therapy. The ongoing advancement in dosimetric technologies with in vivo dosimetry hold tremendous potential to further enhance the clinical outcomes. So we can summarize our discussion as the purpose of IVD is to monitor the treatment delivery to ensure accurate dose to the target and limit the errors as required for the patient safety program. The common dosimeter used for IVD, so diodes are the most popular for real-time monitoring. TLDs and MOSFETs are used for in vivo checks, particularly for skin doses, while APID is used for the exit dosimetry. Uh, the applications of IVDs are commonly used for special treatment like total body irradiation to check the dose homogeneity, SDR high dose rate brachytherapy, and high precision techniques like SRS and SVRT. The procedure involves placing dosimeter at a specific point on the skin or inside the body cavities to compare the measured dose within the treatment plan. But there are challenges like managing discrepancy tolerances, managing air gaps, tissue heterogeneity, and the time intensive nature of their implementation. So, with this, I will conclude. This is a paper by Cho et al., which I have taken a reference for this presentation. So, this is all from my side. Thank you, everybody, for patient listening. So, if I think this was the not a big tough topic.